Neither the El Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
The end of every day, my back hurts, right? All of us seem to have back problems, neck problems at one time or another, and sometimes they get better on their own, and sometimes we need to figure out when we need to seek medical attention. During this next hour, we have experts discussing all kinds of back issues. We're going to talk about pinched nerves, we're going to talk about spinal stenosis, herniated discs, treatments, and all kinds of different ways that we hurt ourselves and not realizing we're doing it. So it's lovely that both you guys are here. As you know, this is a live program, so give us a call. The number is 881-0013. You can ask your questions live. We've got people answering the phones and bringing them our way. I also want to let you know that the Hospitals of Providence are the ones that are underwriting this program for us this evening, and also the Texas Tech Paula Foster School of Medicine, who provide their students to answer the phones, and they're here every month too. And as every month and several times a month, the El Paso County Medical Society has bringing the show to you for several years, 22 years still. And you are watching the El Paso Physician. Again, this is about back, neck pain management and all kind of problems that go along with that. I'm Catherine Berg, and you're watching the El Paso Physician. With me this evening, it's lovely to have a physical therapist with us this evening, a doctor of physical therapy. We have Claudia Garundo, is that correct? Garduño. And then we also have Dr. Carlos Viesca, and he's an anesthesiologist and pain medicine management. So it's really nice because I think in this world, literally at the end of every day, if you have a desk job, if you have a job where I'm working downtown right now, there's 200 construction guys every day, and they're all walking a little this way or walking a little bit that way. And there's something going on with the spine, and we're all in a little bit of pain. So we're going to learn a little bit about it this evening. Claudia, I'd like for you to describe what your title is and what you do all day, every day, so that people at home can go, okay, if I've got a question, I'm going to ask Claudia.
Well, I am, as you stated before, I have my doctorate in physical therapy. And my specialty is in vestibular rehab and concussion management. But I do see a variety of individuals with all sorts of pain, ranging from ankle, knee, hip, up the spine, the low back, the mid back, and the neck, most definitely. And we just treat them one-on-one and evaluate them, see where their pain is coming from and how we can help them.
And everybody's got a little bit of a different issue, right? And that's something we really want to talk about.
And sometimes they come in with maybe a hip problem or a knee problem, and as we assess them, we find out that it's probably coming from somewhere else. It may be up the chain in the lumbar spine or up in the neck. So
this is one of those shows where I just want to forget that the audience is there, and I'm like, let's talk about me, okay? Because I am a lanky person. I got scoliosis. I've got stuff going on all over the place. Dr. Viesca, so pain management, anesthesiologist, pain management. When we look at you, describing you in that way, what is it that you do all day, every day?
Boy,
it's a big question, and maybe for today, we can just keep it with the neck and the back,
correct.
Or even we can just keep it with the neck if you want to.
Well, I mean, in reality, I see things from head to toe.
Okay.
Yeah, pain from head to toe. But if we're talking about neck and back, we see all sorts of things, from pinched nerves, from arthritis that has happened over time, from actually injuries, from some type of work injury, as you mentioned. We see a lot of that. Yes, the fact that we age is going to have a toll on those two structures, back and neck. And we have all sorts of different modalities to treat them with. To me, probably the most important thing is if the patient has been able to see a primary care physician, sometimes an orthopod, an orthopedic physician, orthopedic surgeon, and they have initiated some kind of protocol.
Okay.
And the protocol should be anti-inflammatories, keep moving, physical therapy. If that didn't work, then some kind of other study, X-rays, MRIs, CAT scans, tomographies, and if that shows something, they're probably going to be referred to me.
Okay.
Because that's when you need me. If all of that has failed, then you're gonna need me.
Okay.
80% of the time you shouldn't, and in 2 weeks you'll be fine.
Gotcha.
But the other 20
I love
is
that
where-
note. So on that note, let's talk about when is it time? And let's start with neck. Because I feel like everyone's got a problem with their back, upper back, lower back. And I think sometimes the neck's there, but we just kind of think, oh, my neck's just kind of sore. So let's talk about, Dr. Garduno, I'm going to start with you. When someone has a neck ache, what type of pain is there with a neck ache? And the reason I'm asking this is it a bone ache? Is it a muscle ache? Is it a nerve ache? If you can describe maybe the differences of those pains to describe maybe what, and it's not a self-diagnosing thing, but maybe this could be going on because that's kind of a nerve pain or that's kind of a, you're just tired pain.
And
describe those different types of pains.
And so that's, I mean, you nailed it right on the button there. Everyone can describe it in a different way. So there's no real right or wrong answer to that. You know, someone could come in and say, you know, it's my nerve. I feel my nerve right in here, that it's just in a ball. And, you know, so it's different to everyone. And
Yeah.
it's good to get people to describe exactly what they're feeling. Is it a numbness and tingling? Is it a true muscle ache that maybe only hurts when you actually perform a particular movement? So you got to dig in a little bit more to the person itself because it is very subjective. It can feel very different to different people. But most definitely, it could be something that starts something real little that gradually stays there for maybe about a week or two, where they're not able to sleep anymore, or it's keeping them from doing particular functional activities. So, you know, they're not able to cook as much, or they can't read their book at the end of the night, or
Right.
something like that. So if that starts to happen, that's definitely a good time to start thinking, okay, I might need to look into this a little bit more instead of, you know, maybe just taking an ibuprofen at the end of the night or something like that.
Exactly. And Dr. Viesca, if you can, I can describe what I feel, but I'd love to hear what you are looking for from patients. For example, when I do have that sharp, quick pain in the neck, when I turn funny, to me that's like a nerve pain, because it was quick and it was like, oh, kind of caught me off guard. And then there's that pain at the end of the day, literally, where I just want to take my hand and just rub the, you know, cuss word out of my muscle back there, which is a whole different kind of hurt.
Correct.
So take us through what those two different types of pain could mean, and let's just say the neck area for now.
One of the most important parts will be for how long has it been going on?
Nice
That's my
said.
first question.
Right.
Okay. So if it's been longer than 2 weeks, a month, we consider chronic.
Okay.
Does it happen every time that you turn, or only when you turn under certain circumstances? That is talking about the pinching nerve. Yeah.
Exactly,
The pinch nerve type
right.
of pain. So in that circumstance, we can look at what kind, we call it quality, the quality of the pain. Is it numbing? Because sometimes we feel like, oh, it went numb.
That's a great point,
Yeah.
the numbing
Or
portion of it.
was
right.
it a sharp shooting type of pain? When I turned, it actually felt really sharp and it went down my arm. Yeah, that's different. Especially, is it also just an ache?
Right.
Yeah. So sometimes the shoulder is the one that feels just like an ache, and that's kind of an arthritic type of deal. Yeah.
Ah,
So that's
okay.
what we need to differentiate. And is it burning? Burning involves more of a nerve pain, more of a different type of nerve.
Okay.
Yeah. Now, here's the kicker.
Yeah.
Sometimes they can actually be reversed and
Right.
be the same thing. Okay?
Ah, lucky us.
Because we humans do not act the same way a couple of times, you know. Even the same patient can have different types of pain during different times of the day. And they come and they're really anxious about it. During the morning it's really achy, but then it
Right.
feels really heavy, and then it feels like a burn at the end of the day. And that has to do with you've been doing things all day.
Yeah, what your movements are during the day.
And thanks to cell phones, now we have different types of pain.
You know, we really do. I've noticed that on one side. It's a thumb thing on mine. You know, Dr. Garduno, let's talk about when we have a neck pain and it's a sharp pain. Let's just say that, for example, and I will use me because when I turn quickly to my left, like this is all I can turn to my left, really. And if I turn a little bit more, I feel like there is a bolt of electricity going from the top of my ear. It does not numb my arm. Because every doctor's like, do you feel numb? No, it doesn't. But I feel like it goes all the way down to my belly button. That's like the sharp pain that I get. But when I put my head back, it's fine. It's not there anymore. In my head, and I could be wrong, I think, oh, that must be a pinched nerve. I'm just throwing that out to people who may have a funny, sharp pain when they do something specific, and when they stop, and the doctor says, well, don't do that. You know, it hurts when I do this. Well, don't do that.
Stop. Yeah.
So let's take that as an example.
Right.
If people have that kind of a pain, a pinched nerve, is that something where do I just know not to turn that way? I mean, I'm joking about it.
Yes, but no.
But at the same time, do I come see you?
Yes.
Okay.
Okay, because the last thing you want to do is stop moving. You don't want to stop moving, because if you stop moving, you're going to end up starting to move in this fashion, in a block type fashion, and now you're just restricting all sorts of other tissues, and you're going to start other issues. So no. You need to go and see someone for it. You start that chain now at that small point where it's just a little bit of pain, where it's not numbing, because that's the best time to go ahead and attack it. And you know, it could be different things. I mean, that could be where it could be coming from. It may not necessarily, people automatically think, I've got a, like you said, a pinched nerve, my disc is herniated. I'm going to have surgery, and that's the end of, that's it.
That's it. That's it. It's like you can't have a Thanksgiving conversation after that.
Right. It's all
so this
over.
this is the perfect transition into diagnosis. So let's now figure out, I've got something going on, and I've gone to the orthopedic doctor. They're like, okay, go see Dr. Viesca. So someone comes to see you. They've got these different issues. What is it? What test do you do, or either one of you do, to figure out what is actually going on? Because you said earlier beautifully that sometimes you might think it's this pain or it's originating from this other place, but it could be from somewhere else. So let's talk about, and both of you, however you want to team up on that.
So to me, in reality, their input is actually a lot more important than any other. But in my little assessment, and I'm gonna let Gabby talk about it here in a little bit, but the most important part will be, in what type of movement do you hurt? And what is it causing? How much is it restricting? And have you done physical therapy? If you haven't done physical therapy, really the curative part of any of these issues is physical therapy.
Gotcha.
Once you come to me, I'm trying to fix it by decreasing inflammation, by doing other type of modalities that are more interventional than anything. But I hope that you wouldn't need me. Yeah, because if you, physical therapists are great to start with, and their assessments are actually so complete that they can actually treat better than I can. Yeah. In many of these problems when they first start. That's the truth.
So Dr. Garduno, let's talk about the most common ache that comes your way in the world of neck and back. What is that, and what is it caused by?
So a slew of things.
Okay.
Let's go back to your example of, you know, a pinch in the neck. So how we would first start off is what you feel. I would like for you to describe that pain a little bit more in depth, and how Dr. Viesca was saying, when does it happen? What movement are you doing? What is it limiting you from doing? And then what's your end goal? What's your personal goal? What do you want to be able to achieve with the physical therapy? To me, it might be, I want to, you know, completely take away your pain and restore everything known to man that I'm assessing. But for you, it might be, well, I just want to be able to turn and look at traffic to make sure that I'm safe. You know? So I check to see what your range of motion looks like, just grossly. I check to see how your muscle strength of your neck and your arms are doing. If there's anything noting that some nerve damage is starting to occur where you're not getting any reflexes, or there's some atrophy going on in your arm and you really didn't even realize it. Then I check the joint itself to see how well the joint mobility is doing, if there's any kind of restriction. Maybe you do have a vertebra that might be slightly out of place. We check that, the integrity of it, and the musculature to see if there's any tightness. There may be some soft tissues that are also a little tight or maybe inflamed. So the evaluation itself is very overall and specific. And so it does take us quite some time to get through everything, but at the end of it, we start putting the picture together a little bit to see where we need to then attack the problem.
And when is it that you start looking at then the entire spine? So you've got neck, you've got Again, I have scoliosis. I have one hip that sits quite a bit higher than the other. The legs are technically the same size, but it doesn't seem like they are. So, and I thought, well, this is my neck that hurts. But it's like, you know what? This is actually stemming from your hip.
Right.
Talk me through a situation or a case study that you may have had in the past where someone's just kind of messed up everywhere. So there's x-rays that may need to be done. You're trying to figure out, well, why are they, and again, it's muscle memory, right? So you've learned, my mother, she's been gone many, many years, but she used to tell me, she can hear me coming down the hall, know which one of her kids it is because I wobbled. You know, weebles wobble, but they don't fall. Because I had a very specific duck walk, and she can hear it. And that's to that, where all of us have our own specific gait because of what's going on. So how does one look at the entire skeletal situation there to figure out what might be going on and how to treat it? And I'll start with you, and then...
Well, the first part is actually getting you into a gown and looking at your back. Yeah, that's an observation
and
is the first
feeling
thing.
the vertebrae and
looking
muscles,
first,
and
then
like
feeling.
you said. Okay.
Getting you to walk back and forth in the exam room, and then from there, seeing what is going on. Exactly what you mentioned, the wobbly, the type of gait that you have tells me a lot. Foot drop tells me something else.
Okay.
Sometimes just the fact that you might wobbly to the side, or you might be just not, your gait is not totally in control, let's say. That will tell me something else, which is talking about vestibular, problems. When your equilibrium is not, your balance is not normal. So that tells me it's coming from your brain too. Something more, we call it into the higher neuron centers. So it's all of that. And then listening to what you have to say about where is the pain, how is it, what is it affecting. People sometimes just show up bent over.
Right,
And you cannot get them to straighten up. And that sometimes is your sacroiliac joint, sometimes is just your thoracic spine. So it is an actual, it becomes an art that you have to really, figure out the whole picture. And to me, most patients already come with magnetic resonance imaging, MRIs.
So you have a lot of that information
I have a lot of
start seeing
correct.
patients.
And that is almost unequivocal. I mean, a physical exam can tell me something, but sometimes I'm surprised by the MRI. It shows something totally opposite.
Gotcha.
Yes.
And we have to pay attention to those things. We
So
don't treat
you nodded right away. Tell me an instance when that was the case, when you saw something on an x-ray and you thought, oh, it must be, but it tended to be something else.
I am the complete opposite, because I don't usually get the MRIs or the imaging, so I have to depend on my physical assessment. So sometimes I can kind of already see, from what I've assessed, this person does have a herniated disc somewhere.
Oh, wow. Okay.
So then I recommend that, I send it over to the doctor and let them know, this situation might be accelerating a little bit more. If they haven't had imaging, this is definitely a good time to go get some imaging.
Okay.
Yes, most definitely.
So physical therapy-wise, with a herniated disc, because I feel like everyone has a herniated disc, at least one of them, if not 2 or 3 or 4 of them, right?
Right.
Herniated disc. So if we're now looking at, prior to going into surgeries, if we're trying to figure out physical therapy, some kind of pain management, what might be the ways to start? Like what physically, in physical therapy, what might you do with herniated disc? Like I have, I think it's the C5 and 6 or the C4 and 5. And I also have some bone spurs hanging out there, waving at the world. And it's just neck stretching. That's all I can do until I get to a point where I really want to do something more and surgical. So I'm stretching. Tell us what you would tell the audience in this situation.
So there's so many different things, and sometimes they come with the thinking that I'm coming to physical therapy, I'm gonna get a massage, and you're just gonna relieve all the pain, and it's wonderful. We are not massage therapists, okay? And if there's any of my patients out there listening to me, they've had my type of massages, they've had these pointy elbows on them, it does not feel good. My intent when I do manual work on my patients is to release any kind of trigger points.
Okay.
So If I do any kind of manual work, like I said, I'm going to be assessing the joint. I may be needing to mobilize the joint in a particular way to either get it back into place or relieve a little bit of pressure that needs to be relieved, again, on the nerve or any other soft tissues. And then go from there. Again, soft tissue-wise, is there some soft tissue work that I need to do? Again, I can either use, again, like I said, my pony elbows,
Right.
but there's also different techniques that physical therapists use. There's dry needling that's coming about.
I've tried that.
Yes.
So I'm going to stop for a minute because
Okay, go
I am
ahead,
going
yeah.
to ask, when you say you are manipulating, so what is it physiologically you are feeling? Because I'm thinking too, when I've had physical therapy, they're feeling something and all of a sudden there's this golf ball in my back. It's probably more like a cherry, but there's something that they feel, and you can feel that they're feeling it, and they just press and it hurts.
Right.
So this is the elbowing.
Right.
What are you doing? So they say, well, I'm trying to release the muscle.
Right, a trigger
What does
point.
that mean?
So there's different trigger points that could happen within our muscles. So we're trying to apply the pressure to the muscle that's kind of in a spasm.
Okay.
So it's just contracted.
Right.
So all I'm doing is applying soft pressure, and it does gradually get a little deeper and a little more painful.
Yeah.
Until it does finally release.
Okay.
Now, a little bit more comfortable would be some dry needling, where they're using, if not familiar with dry needling, they're acupuncture-like needles that they then stick into the different trigger points that piston, and we're actually working the neuromuscular, so kind of where the nerve endings meet the muscle. We're kind of trying to reset. It's kind of like a reset button. We're trying to reset that muscle so that it can just release. It's a little more
Okay.
comfortable than, like I said, a little bit bony prominences kind of poking at you.
Well, I've
but
tried it, and
it's
I
good,
I think dry needling is fascinating.
Yeah,
And I'll explain it just from the person who was on the table. I mean, they go in deep. You don't feel all that. But the way that the person who is doing it, and correct me if I'm wrong, 'cause so this is my,
It's okay.
I'm asking every doctor, what are you doing to me? Explain this to me, because if I have to say this on TV, I have to say. She says, well, we're trying to get it to a point, and the muscle knows that the needle's not supposed to be there. So the muscle's going, no, I don't want you there. So the muscle's trying to relax and get that point
It just resets it.
to lighten up. And I literally felt that. It was toward the back of my muscle in my shoulder when I could just feel, because I was like, oh my God, and I had no control over it whatsoever, but I did feel that it released. It was weird, but very cool at the same time.
Yes.
So if you're doing manipulation with your fingers and dry needling, what else is out there? Acupuncture, we don't really
So
talk
you
a
should,
lot about,
and you
but
and
tell
you
me
should
about
once
that.
you do the dry needling or any kind of other soft tissue that we end up doing, it still has to be followed up with some kind of strengthening, because now you've
Okay.
released the muscle that has been in spasm that now is probably a little weaker because it's been so contracted. So
And
then
when you
you've got
say
to-
has been, give me an amount of time that it could be for a couple of weeks.
Oh,
It could
that's-
have been years.
Again, it
could have been.
Yes.
Yes. Look at you.
Yes to all of it.
From a day to 2 years.
Okay.
And so about acupuncture, one thing that we're trying to do more in pain medicine is treat the person as a whole, because there's the psychological, physiological, cultural, and actual anatomical issue. Yeah. So pain is not a symptom that I can measure easily.
Right.
Yeah.
Right.
Blood
Okay.
pressure, yes.
Right.
High blood sugar, easy. Not pain. Pain has to do with the way you were brought up, where were you brought up, who brought you up, what you've been doing all your life. So
What people would
that's
call what your pain threshold is, so to
exactly,
speak.
so
Okay.
to speak. And then
Okay.
with that, you have to think about, is this patient will benefit from acupuncture, from Tai Chi, from yoga? Actually, we're calling patients to get back into their religious beliefs, practice their religion, because that also relaxes and helps. There are substances that when you actually think about God are actually releasing your brain and help you get control of pain. So we have to take all that into consideration before we send you out. And I tell the patients, if any of these modalities gives you 10% pain relief, 10 to 15, but we're doing 5 modalities, that's
Then
about
you've got-
70% of your pain better.
Right.
And imagine if you just can keep doing it. It helps
And
a
it's
lot of
about
aspects of
discipline,
life.
too.
It's discipline.
It's discipline.
Is discipline. I wish I had, the magic pill or the magic injection or the magic
Yeah.
therapist. Most of them are very magical. they are truly. But It just doesn't work that way. It has to.
Right.
It has to be a relationship where the patient is willing to do something for themselves, not just expecting me to do something.
Right. And I love that too, because it is so easy to go to a pill, and then that's also very dangerous. I'm getting quite a few questions here from the audience, so I'm going to kind of blow through these. And I love, thank you very much for putting sex and age on here. That's beautiful. So, female, 94 years old. Hang in there. I love it. Has received epidurals. It sounds like right now she's getting epidurals about once every 6 months or so, but the pain keeps coming back in the shoulders and in the back. Is the pain supposed to return? Is it wearing off because of old age, or, and that's the question. So this is all we have to go on. So that's my disclaimer with any of these questions. But epidurals, there is a certain amount of time.
So one thing that we keep missing, and this is where credentials have a lot to do, who is doing your treatment, who trained them. We need to start asking more. Who are you sending me to, and why are you sending me to him, to her? What are their credentials? And in that matter is, we shouldn't be doing epidurals every 6 months. We should be doing a series of injections if the first one works. That's based on
Nicely said.
studies. That's based on science.
And 6 months, to me, seems like a pretty nice amount of time.
It is a good amount of time, but if I do a series of injections, I should be able to give you years of pain relief in the epidural aspect.
Okay.
When it comes to the shoulder injections, depends on what are we dealing with. We sometimes inject the nerve that gives sensation to your shoulder, and if you get pain relief, then we do something to stun it.
I see.
And that can last up to 2 years.
Okay.
Best case scenario, 2 years. I've seen
Okay.
3, but 1 to 2 is what you want. Because in reality, you should be able to not have to see me for that amount of time.
Right.
I'm hoping to give you that
You're really
amount of time.
cute, but not that cute.
Exactly.
Right? I
Yeah,
gotcha.
I love seeing
Okay.
you, but
Yeah.
it's better if you go and live your life without me. Yeah.
Right. No, that makes
So-
perfect sense. And 2 years, to me, that's, yeah, you know, I keep thinking about myself. It's like, yeah, eventually I'll go, but it's not at the point where it's bugging me yet. Now I just kind of, I turn my whole body, and I look at people that way.
But that's
Versus like,
what you're doing. What you shouldn't. That's what you need to come.
yeah, I shouldn't do that. And then, listen, I mean, here I am. Female 80 on the phone, and says here, has the pain across her back and shoulders, pain in the neck all the way down to the tailbone. She says she's in constant pain. She has done x-rays and has gone to the doctor, but no one has found anything. What could this be? Now, what's talking to me is that the pain goes all the way down from her neck to her tailbone. Again, this is not a diagnosis. That was something we said at the beginning of the show. Nobody's getting sued here. This is just best
right.
case. Yeah.
It could be just postural, you know. So there may not be anything wrong in the X-ray, and lots of people try to hang on to, you know, well, the X-ray says this, the MRI says this, and there are different studies out there saying that, you know, I believe the research went. They MRI'd 60-year-olds, a large group of 60-year-olds that had no pain at all, 0 pain, and ended up having a large percentage with herniated discs.
Really?
So you don't necessarily
But they didn't
have,
know
but
they had
didn't-
herniated discs.
Right, they didn't know
No
they had any,
symptoms
no
at
symptoms at all. So,
Goodness
so you
gracious.
don't hang so much on what the
Right.
diagnostic imaging says.
Right.
It's how you're feeling. So with her, it may be that her soft tissue is not responding well. So she may have a postural issue where she's overstretching some of her muscles.
Right.
So it'd be good to, again, assess to see, does she have tightness somewhere? Does she have weakness somewhere? Maybe one muscle group is stronger than the other, so it's overpowering it. So it sounds more soft tissue.
See, I'm looking at your great posture. I'm lanky, so I tend, I tend to, it's because I feel like I'm on right now. But man, if you see me at my desk, literally I never have shoes on because I have one foot up here, and I'm like this, and
Okay,
I'm on the
that's what
computer.
you know.
But it's super comfortable for me to be sitting like that. I know it's not right, but yeah, I think posture issues for me is true, and I've heard that over and over again from a lot of different people. So I'm glad that you said that.
And let me throw a wrench
Yes.
into that. Now let me give you the medical metabolic possibilities.
Oh goodness.
Thyroid,
Right.
hormones, any type of hormones, female hormones, depending on the amount, high or low, can cause or not cause pain. Vitamin levels, osteoporosis. In an 80-year-old, osteoporosis will be very common, and that
Right.
causes pain by itself as well. Posture, how they sleep,
Right,
what
everything.
they eat, What we eat also has to do with our pain. If we eat a lot of inflammatory substances like preservatives, complex sugars, all of those things don't help. So it's one of those things that there are so many. That's why sometimes when we're struggling to figure out for months what's going on, I go back to basics and I send a
Right.
panel of lab work. I send for a DEXA scan, which is the one that will tell me if the patient is osteoporotic or not. I ask about the mattress, the type of mattress.
Interesting.
Not
Okay.
changing your mattress, for example. For
Right.
those 9 years that you're supposed to, you might have now bed bugs.
Right.
And they might
Oh,
be biting
God,
you every
that's
night,
gross.
and that can be
Yeah.
causing
Okay.
you pain. There's a
Yeah.
lot of things, trust me.
I did not
of
think
that
the
one.
show was
I
going to
seen
go
it.
to
I
bed
seen it.
bugs.
That's why.
I think my mattress is older than that. I shouldn't. Question
change
here
it.
from the audience. No, this is great. In fact, I'm going to throw this out quickly because everything that you said, I want you to say that again before the show's over. It matters because they're all the things that we take for granted
Absolutely.
of how we're living and how we just, oh, I'll get a new mattress some other day, or I'll eat right next week, or now, But I would like for you to repeat all that too in a while. Female 70 is pain in the lower back and then goes down her toes. It's worse when she's sitting or lying down. She feels like this is nerve pain. Question is it nerve pain? We don't know. But again, when we're radiating, I think you were talking earlier about burning sensation, sharp pain sensation. If you were to, either one of you, like somebody's coming to you to get worked on and they're describing the sharp nerve pain to you, what would you say a sharp nerve pain is as to what they're explaining it to you? Am I saying that right? Like, how are they explaining a nerve pain to you?
Right, exactly it. Shooting
Okay.
pain that starts from the back, radiating down the leg.
Okay.
Electrical.
And what should they do if they have nerve pain? Like, is that something, like, is there a manipulation that can help with that?
So
Is there-
for low back, I do end up doing some movements. I have them do a specific type of movement pattern to see if I can reduce the pain, completing a particular movement pattern.
Okay.
So it's all kind of just based on what they're subjectively trying to tell me. But yes,
Okay.
I do try to take them through different movements to see if we can reduce and centralize the pain, is how we end up describing it as a physical
Sounds like
therapist.
stenosis to me, what
Okay.
she's describing. But it will be interesting to know, going to the supermarket, what happens. And you see that patient that you see enter the supermarket and 5 minutes later has to lean on the cart
right, exactly.
couple
yeah.
of seconds and that feels better and they go back. That's a type of stenosis compared to other type of stenosis. But the fact that sitting and leaning down causes leg pain is probably stenosis. And one thing that I really want people to understand, please do not try to reach to your toes when you have back pain because you're only making it worse.
So define what stenosis is. So physiologically,
Okay.
stenosis is what's happening inside your body.
Closure.
Closure.
It's a closure. Stenosis means closure.
Okay.
It's something is closing down on your spine that is now pinching on your nerves.
Okay.
And that's why you have the pain going down all the way down to your toes.
So somehow your vertebrae, something's
So as we grow
pinching,
less young,
closing.
as we grow less young, ligaments thicken, joints
Okay.
grow, bone spurs, and bone spurs are not that smart. They grow into the spinal canal and they cause more
I don't
impingement.
like mine, yeah.
Or they grow into a nerve and now they're pinching on a nerve and they happen
Right.
to be pointy little things. Then you have also the end of our bones, the spinal bones that happen to be like a little rectangle, let's say.
Yes,
Yeah,
yes.
if you look at them from the side,
Right.
they start growing bone spurs where they actually rub with the one on top or the one on the bottom. Because when you rub bone on bone, then that causes inflammatory processes that cause growth of bone.
So that's why
that's a
the
bone
bone
spur.
spurs are growing.
Correct.
Because there's some kind of injury, there's some kind of
Correct.
manipulation, something's
Insidious, something that continues and is always happening. And then
Okay.
you have ligaments, something called the ligamentum flavum. That's a yellow ligament that protects the spine between the back of the joints, yeah, of the spine, let's say. And that thickens and that causes
on. Keep
impingement.
talking because
And then all of that,
nobody on the set
together
freak out. I'm going to get
as-
something up here.
as well as the fact that the exit of the nerves, we call them the foramens. That's, oh, there you go. Perfect. Look at that. So the ligamentum flavum that I was talking about is right in between can I borrow your pencil?
Absolutely, yes.
It will be easier than my thick finger here. So the ligamentum flavum actually lies right in between these two structures. This is called the spinous process. The ligamentum flavum protects between these two structures that are the laminas that are, we have some on the top, some on the bottom. Then another thing that grows, bone spurs that grow into the nerves here. And the bone spurs that I was talking about between the bones of the spine, the vertebral bodies, happen to grow also into the spinal canal and have like this Aladdin shoe tip kind of deal, yeah?
Right.
That goes kind of a lip. So they actually dig into the spine, and that causes stenosis. Stenosis is just closure, diminish, space.
So just that tightness that's happening there. More questions. I told you guys that everyone in the world was going to call on this show, right? Everyone's got an issue. Female, 82-year-old, 2 herniated discs, L4 and 5, thank you very much, that's always helpful. Was told to do PT. How will it help, and what exactly would I be doing in PT? So,
And there's a herniated
Dr.
disc right there.
Garduno, what are you going to make this woman do, for heaven's sake?
Again, it all depends.
It all
on
depends.
It all depends on what
she
she's
has 2
presenting
herniated
with, right?
discs. Again, L4 and 5. Maybe you can kind of point out where L4 and 5 are. So with herniated disc, even if we don't know a lot.
This might actually be her right there.
Yeah.
That the little red right there is a
Okay. So
example
are you
of a
going to get her
herniated
to
disc.
stretch, move around, like what kind of things?
Again,
and I know we don't know a lot.
Yeah, so
but-
I have to assess what her posture looks like, where her strengths lie, where her weaknesses lie. Is there a weakness in some abdominal musculature? Is there some weakness in some back musculature? Maybe even in some hips. Let me move this over a little bit. But another thing that I'd like to add into, especially with the stenosis too, something that we like to use is the aquatic environment.
Nice.
Getting someone into the pool that may
Right.
not be able to move and do some exercises out in the gym. They might not be able to tolerate that real well. We can get them into a pool, an aquatic environment, where the pool is nice and warm. It's about
Right.
92 degrees. It's therapeutic. So they can feel like they can move a little bit better, and then release some of the pressure that the stenosis may be putting on the spine, kind of almost a little traction kind of unit. The
Okay.
buoyancy of the water itself kind of gives that little bit of a traction kind of sensation to help let things move around a little bit more, and then let the individual move around a little bit more.
Right.
And then sometimes they don't really realize, oh, I'm doing great, I'm moving, and I generally tend to limit our first session to maybe about 30 minutes or so, because they don't realize that they're moving. So the next day, they
They're
may feel,
hurting.
yes, they may feel
Gotcha.
very sore.
Okay.
So we kind of curtail it a little bit until
Right.
their progression can tolerate a little bit more.
Nicely said.
And one of the things with water therapy, a lot of people say, "I'm afraid." Well, don't worry, you're not going to be swimming in the
Right.
deep end.
Gotcha.
First of all,
Right. You won't be in the deep end. We'll
and
keep
the other
it at
thing
4
that is
feet.
beneficial is that you're taking gravity, a portion of gravity
Right.
away, and now your joints are not suffering as much, and your muscles are able to work against, better than without gravity.
Yeah, you're lessening the stress
Exactly.
with all of that. We haven't talked a lot about arthritis. Question here from the audience. Female, 50 years old, arthritis in the spine and in the hip. Doesn't give us a lot of information at all. So she's just asking, what can I do? Will physical therapy help with arthritis? So arthritis is inflammation of the joints, if we want to describe it. There's medications for that. So I'm looking at you for medications. I'm looking at you for manipulation. So let's talk about that. Hip and spine. Again, all of us. I've got aching hips too.
So
I'm
before
with ya.
I let you, one thing that I tell patients, because I have a lot of them, I do not believe in physical therapy, and I laugh inside.
The
It's
patient
not-
tells you they don't believe in
yes.
physical therapy?
And,
Oh,
and,
goodness.
and it is not a matter of faith, because physical therapy works with your body and helps you physically.
Right.
So everybody actually can have physical therapy.
Right.
And when they feel that they're hurt at the beginning, it's very normal, because they're most likely been sitting watching TV for a long time.
Right.
So now that you get them to move, it's going to hurt. And they hate Ms. Garduño for a little bit, and then they feel better, but they have to keep going. Yeah. So I'll let you address that with arthritis.
Most definitely. I get that a
Okay.
lot.
Are you hated for a little
Yeah,
while,
well,
and then
yes.
they love you,
And then they
right?
love
But you
me,
hang in there.
And then they start dreaming of me. Claudia, I remember that you told me that I've got to stand, sit straight, and this.
Right.
So once I know that, once they come in and tell me, I dreamt about you last night, I know. I've got them.
Right.
We're doing
Good.
some good. We're doing
Good,
some
good, good.
Yes. So yes, with arthritis, most definitely it's overuse. Depending on what type of arthritis as well, because it could be rheumatic, it could be osteoarthritis.
Right now, describe the difference between the two.
So rheumatic is more your body system is attacking the joint itself.
Okay.
Okay, and osteoarthritis is more overuse. That
Okay.
you know, a good majority of us will probably end up with some type of osteoarthritis just from general wear and tear.
Okay.
But rheumatoid arthritis is more that the body itself is attacking the joint.
Okay.
And in that case, you really don't want to expose the patient to too much. You want them to stay conditioned and strong, but you have to be careful because those joints are pretty much being disintegrated by their own
Right.
body. Their
Right.
immune system is attacking the joint, and it can be very hard for that patient. So they are the ones that require more medication management, psychological management to understand this is for life.
So here's a question, related but not related, but I feel like I'm hearing about it here and there. Joint replacements. When we talk about hip joints, knee joints, we had a hand doc on a couple of years ago just replacing knuckle joints. Where are we in that world when arthritis has really taken its toll to where the joints just really are not operating? I know that this is not your area of
No, but
expertise,
it is.
but I'm curious. So Dr. Viesca,
So-
go ahead.
Well, you'll talk about what you do with physical therapy with them.
Okay.
But we have gotten to a point, and we're not there yet, as in the materials, although they're doing very good in replacing, they're not long-lived. Yeah.
Okay.
If you have them at age
And we're
40,
talking
it's 10
specifically
years.
hand joints,
Well, we're talking
or
everything.
everything.
Everything is really,
Okay.
any joint, shoulder, knuckles, knees, hips, ankles. 10 years is the most that they survive. I have seen patients with 15, but they've done very well with keeping conditioning, keeping their muscles strong. They really,
Right.
gotten into a discipline where they don't want to have it that soon, especially the 40-year-olds. There are
Right.
40-year-olds having knee replacements because of how arthritic their knees were. Sometimes it was related to a car accident, sometimes related to a work-related injury, all of those things. But we're in a place where joint replacements are done by very expert physicians. There are very good surgeons that are doing it today. And I mean, it's kind of tough to really mess up a joint replacement these days.
Right. Good. That's good to know, because I'll probably have some.
And then, you probably see them a lot
Yes.
post-surgery.
Yes,
And pre-surgery.
Exactly, and then definitely you want to, I would recommend doing a pre-surgery kind of visit to me as well to make sure that you get a little stronger. The stronger you go into any kind of surgery, not only just joint replacement, the better outcome you're going to have.
Right.
Just overall, whatever surgery it is. So I definitely recommend having some kind of prehab.
Right.
Is
Prehab,
what we call it.
lose a
It's-
little bit of
it's
weight, everything's
preconditioning.
better on the joints
What you're
either
trying to do
way.
is preconditioning. Even in heart surgery, it exists.
Right,
If you want to need
exactly.
heart surgery, go get your heart a little stronger because it will do better after surgery.
Agreed. I have so many questions here, so I'm going to go with, female, 76 years old, pain in the right neck that goes down her shoulder and all the way to the middle finger, constant pain, and does use a computer for work. So this is why I want to talk to her. And the reason I say that is with physical therapy, fine in the office, but I'd imagine you're also teaching people what to do and what not to do when they're away from the office. So uses a computer for work, and again, she's got shoulder pain going all the way down to her middle finger, maybe the way she's set up. Go ahead and take that away.
So definitely I would still start with work.
Okay.
What does her work setup look like? If she is on the computer quite a number of hours, where is her computer screen? How is it situated, and how is her posture related to the computer screen? Where are her hands? How is she doing as far as her vision is concerned as well?
Oh, good point.
Because again,
Right.
depending on where the screen is, we tend to get into this forward posture where that within itself is already clamping off some nerves. So definitely I would start definitely at work first to see what her setup looks like, and then let's see what she's doing at home. Again, what postures, how
That is
how's she
beautifully
laying
said.
down
About
during
5
sleep.
years ago, I got myself a pair of computer eyeglasses
Mm-hmm.
because my computer sits about there, and that was exactly what I was doing. I'm still fine reading like this without eyeglasses, but it definitely,
Mm-hmm.
and it changed my life. It really did, because that was where that hunch would always come in because you were going forward. So God bless you for saying that out loud.
And you might be, in your car, waiting for the light. Look around you. There's a lot of people that are sitting just like this. So
right.
within the car too, your posture wherever you're at
Right.
really makes a big difference.
Okay, that's a mantra I need to start doing. This one I'm reading cold, but we finally have a guy calling in. Male, he's 75 years old, lifts weights, a barbell. Let me figure out something with his lower back. Sorry. So I guess the barbell, when he's trying to do something with the barbell in his lower back, somehow he stretched something out. And he wants to know what he should do. If it's really bad, go to the doctor. Only because I really can't read all what's on here. Female, 85 years old, 5 years has stenosis. She has arthritis. She has sciatica. Has done acupuncture. She's done pain management with physical therapy. Is there anything else that she can do that maybe she hasn't done? Dry needling, I don't know if that's relatively new. I felt like it was new for me. And if you could, I know I kind of described it in my weird way, but if you could describe physiologically what's happening and really describe it, like the needles are long, they get into, what are you weaving?
So it does depend on the area that they're needling.
Okay.
So if you're needling, say like a glute muscle, so your butt muscle back over here, it's a little thicker muscle, so the needle may need to be a little longer to really access the muscle correctly. So it depends on where you're. So if you're needling a hand, that needle may be a little smaller.
Right.
So the therapist does go through a movement screen first to see, and then again, just going through subjectively where they're having the pain and so forth, everything we've been talking about. But a movement screen to see, how you're doing, how you're moving as a whole first, to see if they're going to be needling the appropriate spot first.
Okay.
Once they determine which spot it is that they're going to needle, they will piston. So it's like an acupuncture needle that they find.
And it's very thin.
Let's
tell the audience how thin it is,
Yes.
because I think when I heard it, needles, like, you're going to give me a bunch of shots? Nowhere near that size. I mean,
No,
it's
not at all.
super duper thin, barely can feel it.
Right, and it
Yeah.
does bend a little bit, because sometimes the therapist does feel a little bit of restriction where they can't get as deep as they need to, and you will literally see the needle bend a little bit. So they do have to kind of wiggle around, like you said, until it does release and they're able to go down a little further. But all they're doing is they're getting into the muscle junction where they need where whatever trigger point they're going at, and they piston. So instead of an acupuncture needle that may just stay in one spot, they just piston it up and down.
And that is doing what to that spot? So let's think of muscles as a fiber. Like, just say we're looking at meat right now, so we've got these fibers. When you say piston, is it through different types of fiber or through?
No, because they're not actually lifting and poking to a different spot. It's the same spot that they're pistoning
Just
in.
going up and down,
So they're
up
not
and
really
down.
taking out and putting back in. They've already inserted, and they're just pistoning back and forth within that unit until it does release a little bit. And the best way that I can describe it is just like hitting the reset button on your VCR or your DVD
Okay.
player or something. But it's that neuromuscular junction that they're trying to assess to just release it and kind of trick the nerve almost into saying, "Oh, okay, yeah, I'm good. I remember."
So on that note, that releases the muscle, the knot, the whatever it is, for a while. And chances are, or as I've understood, knots kind of come back for the most part in the same places again. Is that because our muscle memory in our bodies, we just have our own movements and we're just not paying attention and that's coming back? Is there a way to... Dr. Viesca, I'm asking you.
No. It really
because I feel like, okay, I've had that done, and I'll do it again. How can I just keep that knot to be gone? Is that even a
to
thing?
me, is going to the source of the reason for the knot.
Right.
Okay. So when you have that knot, is because something else is triggering it, and the more simple way, if it was just tension, and because you're tensing up, you're causing the knots yourself.
Exactly.
That would
That's
be the
my point.
simplest way to treat,
Right.
because then we only need to focus on your stress.
Right.
But if that knot is caused by a pinched nerve or arthritis of your neck, joints, then that requires for that pinched nerve to be treated, and the knot will go away if the pinched nerve is not happening.
I see.
Yes.
Okay.
So that's why they shouldn't be coming back. If they keep coming back, it's because we're not doing something right to treat you, or you're not following instructions the way you should.
Right.
And for example, you talk about your pinched nerve. It's actually very simple in a neck. It's very simple to treat. With certain exercises to keep open the foramens and things, and you pull to that side, and you remind yourself every so often, it shouldn't be happening anymore, and your range of motion should come back. That's something where Gabby can help you, Ms. Gardeno can help you, and you ought to focus on it, because this is what you do for a living. But we forget those little things, yeah. And I try to treat the source. So when
Right,
you come to me, I
exactly.
treat the source, because it will be very simple to be just doing trigger point injections.
Right.
A lot of physicians, because of the lack of training, say, oh yeah, I want to do your trigger point injection, and you'll feel great for a couple of weeks, sometimes months, but if we're not treating the source of that knot, then we're missing the point.
Nice. Nicely said. We are at a point where we've got about 9 minutes left in the show. I do have quite a few questions left, but what I want to do is, before we go further, is there anything that you wanted to get across this evening that we may not have talked about yet? You're a veteran, so you kind of know that that's how we roll. So I'm going to have you go first. Okay. So this is that time where, I really wanted to make sure that we got across A, B, and C to the audience tonight. And this show, like I said, it goes by so fast. How about you? Is there anything that and I love, you're absolutely right, and I'm taking this as my own homework, is really redo my exercises, because there's 2 or 3 days that go by and you're like, dang, my neck hurts, and then I start, and I do them in the car. I mean, there's all kinds of places you can do it. You do the, the static, what is it, make yourself have a double chin. But you're absolutely right. We have to advocate for ourselves and do that with ourselves.
Absolutely. I mean, a couple of points that I love, how I can educate patients, yeah? And if we talk about neck and head, think about your neck being almost a quarter of the weight of your head. So when you do this, you're putting a lot of strain on your neck.
Right.
Yeah?
Right.
We're seeing things that we were not seeing before, now that we have all these devices, where we're growing bone spurs where nobody has ever grown them before.
Oh my goodness.
Yeah, at the base of the skull, now
That
we're
makes
having
sense.
things
Yeah.
because we're doing this. So always keep it at eye high. Please remember that. CBD oil and marijuana, we haven't found anything really when it comes to
And that was
actual,
not even one of our questions.
with
Look at
actual
that.
studies,
Yeah.
because I know that I have a lot of questions from patients in my office. Can I start using CBD? We don't have anything that is actual literature, actual research that shows and proves that is helpful. Okay, actually, there's a lot of issues that are happening in the states that have allowed that. So then, when it comes to your back, now I have back pain for a year.
Right.
Yeah, that I never had before. I standing for long periods of time, leaning on patients doing procedures day in, day out, has now taken a toll. And I have to remind myself on posture, I have to remind on stretches, I have to remind myself on all of those things. A lot of the things that we suffer, once we go to the right people, to the right providers, we get the tools to actually take care of it ourselves.
Right.
Yeah.
Yeah.
And we don't have to be going to that provider all the time. Yeah. I have gone twice now to the physical therapist, and I mean 3 times since the pain started. Only when it really exacerbates, and most of the time exacerbates when I have not done what I should have been doing.
Look at you. No, I love
Exactly.
this. I love it when the doctor's the human being on the show.
Trust
Really,
me.
it makes all the difference.
But
Yeah.
I understand my patients a lot better.
Yeah.
Not that I have migraines, I have other things, but you have to function and you have to treat others. So you're giving yourself to others. That's fine, and it's day in, day out. But you also realize that you have your weaknesses. So I realize and I understand my patients, but patients have to understand. Please help us help you. Yeah?
Exactly. Exactly. Nicely said. How about you?
That if anything, I would just strike that home.
Okay.
It is, and when you come to me, that's exactly what I want to do. Is I want to make sure that you have the tools. You understand where it's coming from, first and foremost, is the education and how you understand where it's coming from. It's not just that herniated disc. Don't just rely on it's there and it's not going to go away. The MRI says that it's still there.
Right.
But it's not really that. It's the tools that I'm giving you. If it's feeling better, that's exactly what you need to continue doing, and just continue doing it. Stay away from the bad posture. Stay away from, if reading in bed is going to be causing your pain, get some kind of pillow or something, whatever we've discussed, to help modify that particular activity, so you can keep doing that activity, but just in a different way.
Right.
But just continue doing the tools that we've given you to continue on.
One of the things that when I remember is to just rest my head on when I'm driving, because I'm driving a lot, I feel like. Just rest on that's what that thing's there for. It's there to keep your axis, but just put it back, because it makes you,
it's kind of a biofeedback. Yeah, it's kind of a little trigger.
It actually feels really good. It's like, you're still driving, but it's one of those big but small things.
So
yes.
Before you move on, let me just mention, we have a lot more tools today, a lot more procedures that are minimally invasive that we can do, ablations of nerves.
Let's talk about that really quick, yes.
For example, for arthritis, for that, where did it go? Okay, disappeared.
Yeah, he was in the way. Dr. Bones is gone.
In some of the joints of the back is what we treat with that. Ablation of the nerves that gives sensation to the joints is what we treat.
Okay.
And that is a procedure, that is a very simple procedure. It always follows physical therapy before and after. So we follow the procedure after patients have done physical therapy, because I want muscles to be strong in their backs, and then afterwards we want them to actually keep having strong muscles. So this is what we're talking about, is these joints right here. I hope I'm pointing at the right.
Hold on just a second. Let me move this to you. There you go.
So there you go. So right here, these little joints that we see, they're called the facet joints. And what we put is a needle right here first to numb it up, and if that gives pain relief for a couple of days, then we go ahead and burn the nerve that gives sensation to that joint.
Really?
And it's burned with radiofrequency thermocoagulation. And right now there's something called cool RF. The only thing that cool RF does is that it causes a bigger area of ablation.
Right.
So that your chances, if you are not that good at the procedure, you don't have that experience with the procedure, it gives you a higher possibility of actually hitting the nerve. But when you know what you're doing, you really don't have to use cool RF. But that's something that makes it for a more successful procedure. But these are procedures that can give you up to 2 years of pain relief. When it comes to that ligamentum flavum, the yellow ligament, we now have things where we can shave it just through a port. We don't have to open your spine. And patients get 90 to 95% of the time pain relief.
Lovely.
So all of those things, actually we have available to us, where patients don't have to go to big surgeries or to have anything else. So patients have to remember that as long as they're being treated, by the right physician, there's a lot of tools, and it doesn't have to be repeated injections. I forgot to mention that. To that person that is having injections every 6 months, either the series is what they need, or they need something different than just going to injections. Because once we have pain relief from something, we believe that's the only thing that will benefit. No, there are other things that can follow that. And that's where you need that person that has that expertise.
I love that. We very unfortunately are out of time, but by all means, watch the show back again at kcustv.org. This is PBS El Paso. You may have noticed that there is some brand changing going on. It's always KCOS, but PBS El Paso. The website, etc., is going to be that way. Also, the El Paso County Medical Society will show this back to you, and that way sometimes it goes so fast, so you can watch us back and get all that information. I so appreciate you being here, both of you. Thank you so much. I'm Catherine Berg, and you've been watching the El Paso Physician. Good night.